Thank you very much for this kind introduction. Good afternoon, ladies and gentlemen. I would like to share with you today in the next 20 minutes a couple of clinical data from an experimental drug which we are developing for the treatment of allergic diseases like asthma or hay fever. Before going into these details, I would like to tell you a little bit why we think immune stimulation is needed for the treatment of asthma, which is a little bit counterintuitive given the fact that asthma is a chronic inflammatory condition. And second, why we need nanoparticles for this purpose. The prevalence of allergic diseases like hay fever or asthma has grown dramatically in the last 100 years. If you go back into the records of the Swiss Army, for example, which are still available today, in the year 1900, less than 1% of the young Swiss males have reported about a disease which we know today as hay fever. Today, that number is well above 20%. About 10% of all children today suffer from asthma, and about 7% of all adults. Now, there has been for a long time a debate why this dramatic increase has occurred in the last 100 years. One school has argued that there might be some toxic factor in our environment which actually causes this increase in disease prevalence, whereas another school has said no, the opposite might be true. Given our hygienic environment in which we live may mean that something may be missing actually in our organism today, which could lead to this increase in asthma and allergy prevalence. And this latter hypothesis has actually gained a lot of support about 10 years ago when a number of articles were published which showed a strong inverse correlation between chronic bacterial infections and prevalence of allergies and asthma. And in particular, what has been shown is that if you are a carrier of mycobacteria, which are actually the bacteria which cause or which can cause tuberculosis, then you're almost entirely protected from developing asthma or allergies. In fact, only 6% of the people that you would find in the general population who have asthma develop asthma when they are infected with mycobacteria. Now, there are two important things to know about mycobacteria. The first one is that throughout the entire human evolution, they have been part of our body. 100 years ago, everybody was infected with mycobacteria. And the second important thing is that these mycobacterial infections are lifelong and chronic. The body contains these infections in so-called granulomas. These are structures which are built by the immune system in our lungs, and usually nothing happens. And tuberculosis only breaks out if we actually get an immune defect so that these bacteria can spread throughout the entire body and then eventually even kill you. Now, what might have happened is that our immune system has evolved in the constant presence of these bacteria, which means that they delivered an immune stimulation, and when now from one generation to the next, as a result of hygienic development, as a result of antibiotic use and vaccine campaigns, that we are today left with an immune system which was simply not made for such a clean world. And this is why we have tested whether delivering an immune stimulus back to the immune system, a very specific one, might actually improve these allergic conditions. Now, we obviously can't infect people with mycobacteria today because that would be too dangerous, but what would be another way to stimulate the immune system? And to explain this, I would like to explain you how our immune system at all recognizes that there is an infection ongoing. You all know about antibodies and about T cells, which can kill virus-infected cells that you've seen before. But what is really the first line of defense of our immune system? That it recognizes that there is something going on in our body. Now, we have a family of receptors which are called toll-like receptors, and these are encoded in our genome, which means that we are born with them. And these receptors recognize certain substances per se as foreign. And among these substances are, for example, cell wall components of bacteria. Double-stranded RNA is something which happens actually only when there is virus replication ongoing. So we have a receptor which recognizes that there is viral replication ongoing. And then we have also a receptor, and this receptor is called toll-like receptor 9, which senses the presence of bacterial DNA. Now, you may say that DNA is DNA, it doesn't matter where it comes from. Of course, it consists of 4 bases. However, there is one fundamental difference between human DNA and bacterial DNA, and that is that human DNA is methylated on certain motifs, and this methylation is basically resulting from post-transcriptional regulation, which exists only in higher eukaryotic animals and is not existing in bacteria. So when CG motifs remain unmethylated, then this is a signal for our immune system to recognize that the bacterial infection is ongoing. And this is exactly what we are doing with our experimental drug, which is called Q-beta G10. And this drug consists of bacterial DNA, which is produced synthetically. It's a 30 base pair long piece of DNA, which binds to toll-like receptor 9. And this is a signal for the immune system that there is an infection ongoing. And our drug essentially mimics what these mycobacteria, we think, have been doing. Now, DNA as such is, from a pharmacokinetic point of view, not a very good drug because it's degraded immediately in our body. We have DNases in body fluids, and it would be cut down immediately. Now, some competitors of ours have tried to develop these TLR9 ligands by chemically modifying the DNA so that it's no longer degraded in the body, and these approaches have actually not worked. They have also tried this in larger studies for allergic diseases, and this was not successful. Our approach is different. What we do is that we package this ligand, this DNA, into a virus-like particle. Actually, usually I don't talk about nanoparticles, but rather virus-like particles. But since this thing is 25 nanometers in diameter, I'm usually invited to these kind of meetings where we talk about nanomedicine. So it's a very small particle, and in fact, it's important that it is small, as you will see on the next slide. This particle consists of 180 protein molecules, which self-assemble to form a icosahedral particle, which looks basically like a football. It consists of 6 and 5 rings. And by packaging this ligand into a particle, we can achieve 2 things. First of all, the DNA is protected from serum degradation. And the second thing which we achieve is that this DNA is transported to the site where we need it, namely into the lymphoid system. Our immune system takes place in lymphoid organs, which are the spleen or lymph nodes. And when we inject it, let's say, into the upper arm, we have to make sure that this thing reaches the lymph nodes, which are actually here in this region here. Now, what happens is that these particles are transported through the lymph system into the adjacent lymph nodes. And now, to make things more complicated, toll-like receptor 9 is not expressed on the cell surface, but in so-called endosomes. And these are vesicles which sit inside the cell. So since this is a particulate matter, the so-called antigen-presenting cell or dendritic cells, they engulf these particles, and within the endosome, they degrade the protein shell, and the toll-like receptor 9 agonist, the DNA is released where it can interact with its receptor. Initially, we were always scared that since this is a protein particle, that we would get an antibody response against it, which would neutralize the whole thing, until we found out that actually the antibodies which are exerted against the particle are indeed needed for efficacy, because this uptake into these immune cells occurs only if we have antibodies sticking on the surface of this particle, and these facilitate actually the uptake. Now, why do we need a nanoparticle, and why wouldn't, for example, a styrene particle also do the job? Our lymphatic system has basically 2 functions. One function is to make sure that fluid, water basically, is transported back from our extremities into the blood. And this is why there are actually small holes which allow water to flow in, but which keeps everything out. And these holes here, they have about a diameter of 100 nanometers. The second purpose of this lymphatic system is actually to transport either fragments of bacteria or viruses through these channels into the lymph nodes or into the spleen. So what we have done is to investigate how large two particles have to be, and these were actually plastic beads which we've used in order for them to reach the lymph nodes. And what we found that while large particles above 1 micrometers also make it into the lymph node, they do so actually through a different mechanism, namely by cellular transport, and then they end up only in a particular area of the lymph node, which is the T cell regions. However, if we make them small, these are 20 nanometer beads, we can actually target them into basically all regions of the lymph node, which makes them much more effective. Now, what happens downstream of that immune stimulation has been described by other parties, and I would like to just to show you this slide here, which comes out of a review article. It has been shown that these TLR9 ligands actually have an impact on both the immediate early reaction upon contact with an allergen. This is basically when somebody with hay fever walks next to a blooming field, and then it takes only a few seconds until he has to sneeze. And this is mostly due to a process which is IgE mediated and which leads to mast cell degranulation, which then produces all the unpleasant effects. There is a second so-called late phase reaction, which is triggered mostly by Th2 cells, which leads then to the chronic inflammation of the lungs. And this late phase reaction appears to play the key role in asthma. You have a chronically inflamed lung, which then leads to mucus production and to the problems actually in breathing. Now, before going into the clinical data, I would like to show you very briefly how we produce these nanoparticles. It's actually not so difficult. As you will see, we produce the protein which forms this capsid, and this virus-like particle comes actually out of a so-called bacteriophage. This is a virus which naturally infects bacteria, which has no implication whatsoever in human pathology. It's there only as a carrier. So we produce this protein in E. coli bacterial fermentation and purify it, and then we have it there as dimers. And what we do next is that we simply add the DNA, this 30 base pair long stretch of DNA, and then the particles are formed in a self-assembly process. Now, obviously, the regulatory authorities wanted us to show that what we produce here is consistent and is always made up of the same amount of DNA, the same amount of protein. And initially, of course, we thought it might be difficult to make sure that there is always the same amount of DNA packaged into these particles, until we found out that nature actually provided for the solution of it, because what we found is that if we give, for example, less DNA in a molar ratio, we do not get less DNA packaged into each particle, but we get less particles. So these particles have the tendency to always take up the same amount of DNA, and these are about 1,920 nucleotides, which we get into these particles, which corresponds to a little less than half of what is naturally packaged through the Q-beta genome in this capsid. So it's a very robust manufacturing process which has been scaled up to industrial scale, and the cost of goods for one dose of this product are about 1 Swiss franc. Now let me come to the clinical trial that we have conducted in Germany last year. This was a study which was done in 5 hospitals in patients who suffered from persistent allergic asthma, which required a long-term therapy with inhaled corticosteroids. These were so-called step 3 or step 4 patients. They had a medium to high dose of corticosteroid, which they had to inhale. On average, these patients have had asthma for about 15 years. The study was double-blind and placebo-controlled, and what we have done in this study is that we have converted the patients upon entry into the study onto a standardized corticosteroid, and then we tried to control them on this corticosteroid, and then what we did is that we made them uncontrolled in a controlled fashion. Namely, we reduced the steroid dose after 4 weeks into the trial to 50%, and then after 8 weeks we took them off the corticosteroid completely. And that was done to induce symptoms of the disease in a controlled manner, so that we can then investigate the effect of Q-beta G10 versus placebo. The patients have received 7 injections of either our drug or a placebo. We had 3 clinical endpoints that we looked at, and I will guide you briefly through those. We had distributed to the patients electronic diaries in which they recorded daytime, nighttime symptoms and use of relief medication. We measured their lung function objectively by a machine which basically measures how much air somebody can exhale in 1 second. And then the most important endpoint, we conducted a so-called Asthma Control questionnaire, which is used today in clinical practice to determine whether somebody is adequately treated or not. These are the baseline characteristics of the patients. I think there is nothing very interesting about that one. Let me skip that slide. This slide shows the patient disposition. We had 2 early discontinuations in each arm, in the placebo arm and in the active arm, and the data that I will show you come out of the so-called intent to treat population. This is the most basic method to analyze a clinical trial, which actually takes into account all the 63 patients that we have treated. The first endpoint was self-reported by the patients. They put into this electronic diary every day how many daytime symptoms or how bad the daytime symptoms were. They gave them between 0 and 4 points, nighttime symptoms between 0 and 4 points, and then they had available a short-acting beta-2 agonist which opens the bronchi, and then depending on the number of puffs that they took, it got 0 to 6 points. And now the so-called symptom and medication score basically is the average of these 2 subscores. And the result of the study is shown on this endpoint is shown on this slide. If you focus first on the orange line, you see how the placebo patients did. You see after 4 weeks, when we reduced the corticosteroid to 50%, they deteriorated, and they deteriorated again after 8 weeks when we actually put it down to 0. Now, when you look at the blue line, you see that throughout the entire study that the patients do better than at baseline when they were on a corticosteroid. Overall, the difference between the 2 groups were highly significantly different, as shown in the repeated measures analysis, and what you also see is that already after 2 weeks of treatment did we get the first time point with a statistically significant difference. Now, if we look at the 2 subscores, we see, this is now the symptom score alone, we see that the actively treated patients had about 30% less symptoms at the end of the trial, despite the fact that they stopped inhaling corticosteroid, whereas in the placebo patients we had about 30% more symptoms at the end of the study. And what these placebo patients did is that they basically compensated the lacking corticosteroid by a doubling of their beta-2 agonist uptake, as is shown on this slide here. Also here you see that from week 6 onward, at each time point did we see a statistically significant difference between active and placebo. This slide shows the result on objective lung function, which was measured by the FEV₁ value, which stands for forced expiratory volume in 1 second. And what you see here is that the placebo patients lost throughout the trial about 250 milliliter of forced expiratory volume on a baseline of about 3 liters, which means that about 8% of their capacity was lost. And these 250 milliliter are about what you actually will find if you look at placebo-controlled trials of inhaled corticosteroid products. They actually add 250 ml versus placebo. And this is what we found here, basically the other way around when we took it away. The actively treated patients, however, they maintained their lung function, again, in the absence of inhaled corticosteroid. So we could actually take them off corticosteroid and it had no apparent effect. The last endpoint is the so-called Asthma Control questionnaire, and this is used actually to find the appropriate medication for a patient today in clinical practice. This questionnaire consists of 7 items. 5 of those are patient-reported, which are, for example, whether somebody wakes up at night due to asthma, whether the person had morning symptoms, limitation of daily activities, shortness of breath, and wheezing. And 2 of the items are objective items like the amount of bronchodilator that has been used and morning FEV₁. Now there are 2 important thresholds on this control score, and the goal for every patient is to be at or below 0.75 points, because this is the definition for being well controlled. And the current treatment practice is such that the physician adds one medication on top of the other until 0.75 points are reached. Now you see at baseline, this is always the average of the 2 preceding weeks, that the patients actually on the corticosteroid therapy did not achieve on average this threshold for being well controlled, the 0.75 points, whereas from week 4 onward, our actively treated patients were on average at or below 0.75 points. Again, despite the fact that corticosteroid was withdrawn. The second important threshold is at 1.5 points, and this is the definition for being uncontrolled or loss of asthma control, and above 1.5 points, the risk for developing asthma exacerbations or being hospitalized is actually growing dramatically. Now, what we've done in this analysis is that we have counted the fraction of patients which was indeed well controlled at the different time points, and what we found is shown here. Under the corticosteroid therapy, we had on average 40 and 42% of the patients in these two arms which were well controlled, whereas at the end of the trial, 67% of our Q-beta G10 treated patients were well controlled in the absence of corticosteroid. And in the placebo patients, we had a decline to about 33% on this background. Is there a need today for additional asthma drugs? There are about 5-6 different drug classes available today. And if you go into the literature, you will find that there is indeed a large medical need to improve asthma therapy. This paper here was published in 2006, and it was a very large field study in which basically patients have been investigated in regular therapy, and it was determined whether they were actually indeed well controlled with what they had available, and it turned out that only 28% of these 3,500 patients which were recruited by physicians were indeed well controlled, and 51% of these patients actually were uncontrolled. And this shows that there is indeed a big medical need, and this is actually the conclusion of the study, was that this study shows that patients with asthma receiving regular maintenance therapy still have high levels of inadequately controlled asthma. And our proposition for this experimental drug is that it shall be used primarily for the improvement of asthma control. This is an overview over adverse events. We have conducted a total of 3 large or relatively large placebo-controlled studies with 430 patients. The systemic side effects are similar to what you see under placebo. What we find, though, is that we have in about 5% of the patients local injection site reactions, which consists of reddening, itching, and pain. In most instances, these were rated as mild and have always been self-resolving. So overall, the tolerability profile of the product is very, very good. So the conclusions of this study are that Q-beta G10 has shown to rapidly and strongly improve all objective and patient-reported outcome parameters of allergic asthma. 2/3 of our treated patients have been well controlled despite corticosteroid withdrawal. Treatment was safe and well tolerated. I told you we have so far 423 patients that have been treated with the drug. From all our work on mechanism of action, we understand that the drug has strong anti-inflammatory properties, which may actually have also an impact on long-term disease modification, but this of course has to be shown in large studies. Then G10 is actually DNA. It's a natural molecule packaged into a natural protein particle, so this is biodegradable and follows basically the same pharmacokinetics as any protein or DNA that comes into our body through an infection. We think the product should be primarily developed for the improvement of asthma control. We think there is a big need to actually reduce uptake of symptomatic drugs. Since about a year, so-called long-acting beta-2 agonists have come under fire by the regulatory authorities due to actually deterioration of asthma which they induce. So you treat symptoms but make your disease worse. This is not exactly what the idea of medicine should be. So there is a big need on that end. We have shown in previous studies that Q-beta G10 also works in hay fever or rhinoconjunctivitis, and there is a large proportion of patients who suffer actually not only from asthma but also from rhinoconjunctivitis. And long term, I think we see a good potential for disease modification so that we know not only treat symptoms but actually the underlying cause of the disease. This is an overview over Q-beta G10. I hope that there is some time left so that I can take some of your questions. Thank you very much for your interest.
Yes. Thank you, Wolfgang, for your very nice presentation and the very promising data. Yeah, there is indeed some time for some questions. I would say 3 questions, and then we have to go to next.
This is beautiful data. Congratulations. What is the treatment schedule?
This treatment schedule was bi-weekly. However, we have from our study 08, we have follow-up data now up to a year, and there we had without retreatment still a statistically significant effect after 12 months. So we think, and our understanding is that that long-term effect comes through an induction of so-called regulatory T cells. This is a cell population which basically self-limits our immune responses, because often, I mean, the most dangerous thing usually in an infection is not the virus, but the immunopathology which our immune system induces, and these regulatory T cells, they actually contain the level of an immune response. And we know that this product induces regulatory T cells. This is why we think that this long-term effect is possible.
A recent study of mothers who were exposed to a farming environment had been shown that their children had a smaller incidence of allergic diseases and hay fever. This study also showed that the genetic makeup of the patients was important. Did you look at that? Did you see similar things?
Well, I think the genetic makeup, I think what might happen is that you have actually what is an epigenetic effect, which could actually be inherited. I think the time of these 100 years is too short for any selection process that basically some humans survived and then replicated. But what actually happens is that the epigenetic, which is basically this is a system which controls gene expression, this is in fact inherited. And this could be that, and this is now my personal interpretation, I think the reason why children on farms have less allergies and asthma is due to the fact that there is way more bacteria out there, and bacteria which do not cause any clinical effects, but which just infect you, and they are there and they do nothing if you live with cows and pigs and all kinds of animals together. And in urban populations, this is missing. So I think that all makes a lot of sense.
So, 2 questions going in that direction. The first is that, first of all, bacteria are always around. So, I mean, your injections, you do them once, and you just explained before that the effect lasts for a year, but will it last for longer? And is there another method to give the drug to the patient than injection? So if it didn't last for longer, could we inhale that drug?
Potentially. We have not tested that in an inhaled format. I don't know. I think there is 2 different, you have to discriminate between bacterial infections which are cleared and chronic bacterial infections. And what makes mycobacteria so special is that they are there for really the life, and they live in the lung, obviously. So in that organ, which then later on causes all the problems. So this is why probably the strongest link has been observed in mycobacterial infections. But of course, many other bacteria are in our body. I remember articles that since we have all these nice methods to quickly sequence genomes, what people did is that they just took out bacteria from our gut, which nobody could ever cultivate on plates. They are there, nobody ever found them, and when you start sequencing them, there were sequences coming up about which nobody knew. And the reason was that we could not cultivate these bacteria, but they are there. And